Hi. Hopefully you can all hear me. We should have a chat bar so that you can type some questions in if you've got any questions as we go. We're going to also use the Facebook page that we've set up. So it's at MTECPD. It's the COVID-19 one that we put together the other day. So hi Rebecca. So yeah, if you want to put any questions in that group as well, then we'll try to answer them amongst the team. So what we're going to go through today is a bit of a snippet of our movement therapy diploma course. So this is the kind of thing that we go through clinical reasoning and how to kind of sift through pathology. So this session is probably going to be about half an hour, 45 minutes, and then you're going to have some work to do as well between now and Wednesday, and then we'll do another session on Wednesday night. I'll create another link so you can register for that one as well. You can auto register, so you'll get automatically informed if we're doing any other webinars. So if you want to do that, then that's no problem at all, and then hopefully you'll be able to keep in the loop with everything. So my clinic is closed. We closed on Friday. For doing that, I think it's I need to keep my brain tick off. Hopefully you'll benefit. And as I mentioned, I've got my clinic as well in Birmingham. We run a multidisciplinary clinic. So we've got a team of osteopaths, we've got sports therapists, we've got strength and conditioning guys, and we all we've all stopped now. So we're all going online, and hence the education going online as well. The other kind of things that I'm thinking about doing is for maybe as a recap for some of you, I don't know, but or if you're just starting out in the industry, then I'm an anatomist as well. So I'm thinking about doing some anatomy sessions. So if you've got any things that you want to cover on that as well, then we can do some short sessions on anatomy. Those of you that know me and know my course, we did a face-to-face course just before everything closed up, and we managed to get hold of a cow's knee from the local butcher, and we did some dissection on that. So we might be able to do some live dissection if I can get hold of anything. Yeah, we'll keep you informed about that. Let us know any kind of areas of the body that you want to have a look at. So this is the plan for the week, and I'm going to change it every week, and I'm going to do this continuously until we're back at work again. So this week is going to be just the shoulder, and then going forward, then we'll choose different body areas. So I asked for some ideas for the topics that you wanted to cover, and there was quite a few things came through on techniques and testing. So I think the best way to do all of those things is to put it together as a clinical plan, so to show you where all of those things fit in. So we're going to have a look at case history, SOAP notes. Some of you obviously may be familiar with that. Apologies if the sound is dropping in and out. I think because everybody is at home and on the internet is really laggy. So apologies. The video will be available online for you to have a look at. You've got 2 days so that you can revisit this video. So if it does drop out, then don't worry. You've got a couple of days to have a look. Key thing, we're going to have a look at red flags and pathology to do with the shoulder. And then on Wednesday, looking at an assessment plan and what kind of tests that you might do for the case that we're going to present today. And then assessing and risk stratification. So looking at, do I need to refer this person, and who do I refer them to? And we're going to get you guys involved in coming up with a treatment plan. So this is the plan for the whole week, and we're going to cover probably these two, a little bit of that one today. So just a couple of tips before we start. I've added these in, so you should see something flag up now. I've pointed you towards some specific books that might be of interest if you haven't got them already. So that one that's just popped up there, that's this one, Differential Diagnosis for Physical Therapists. The whole session, all of the sessions that we do will be based around this book. It's something that I used when I was studying as an osteopath, and we found it really useful. So if you've not heard of it, then it's definitely one worth getting. So that is should be popping up now. We've also got this book in the middle, probably been one of the most influential books on my career. So this is a book by Laura Mosley and David Butler called Explain Pain. And you can get this, I think it's only available on Kindle now. So I'll just show you that one. So that's a link for that one just coming on now. And then, so this one, we're going to explore a little bit of this as we go through and talk probably a little bit more about this on Wednesday and Friday. And then this one here is The Physiology of the Joints by Kapanji. And if you're a visual learner, then this is probably one of the best books for that kind of stuff. It's got really cool diagrams of how the joints move and what movements the muscles make on the joints and how they impact the joint movements. And it's really nicely laid out, so it's worth having a look at that as well. So those are a few books. If you want me to send you the links afterwards, then I can do that, no problem at all. So what we're going to have a look at today, first thing is oh, cool, good. Well done, Natalie. First thing today is your first appointment. So what you have to do is basically sift through loads of information, and we call it a sieve. When I was studying as an osteopath, we used to call it the osteopathic sieve. But it's not just about osteopathy, it's about musculoskeletal health. So anybody can use this kind of sieve process, and that's what I'm going to talk you through today. You should have all seen this before. So we've got our SOAP notes. So the first thing we do is we take a subjective history from the patient. And what we're going to do in this session, I'm going to give you the details of a fictitious patient, and you're going to extract the key information, and then within the group, we'll then come up with an objective assessment plan. Okay, so we'll all work together. We'll use this session here, and the chat box is here, and we'll also use the Facebook page as well. I understand as well that some people might be new to this kind of thing. So if you're a bit worried about putting information down and asking questions or anything like that, if you direct message me, and then I can post it on your behalf. So if you feel a bit funny about the kind of knowledge that you have, then it's not a problem at all. Okay, so it will come from me. The group page is on Facebook, and it's called MTECPD. So if you type in at MTECPD, then it should come up with our page. So subjective history and a little bit. So this is really important. There's no recipes. There's no right answers to this. The only thing that you have to do is justify your thoughts. So there's no, don't just put things down willy-nilly. You need to have a justification for why you've put what you've put. Okay, so that's really, really key as we go through. So this is the plan. Second session, we plan what kind of things would you look at, and then the third session is your plan. So what interesting study that Dan Lawrence from Rocktape told me about. Is back in the 50s, and the problem is we've got we are swayed by what other people say. So if this is where this kind of thing is makes things immediately biased. So I think the best thing to do after this session is to not look at what everybody else has put, and you just come up with your own ideas, and then you post yours. So what this study was about was it took a group of, I think, about 20 people, and there were 19 that were in on it, and there was one that wasn't. And they showed people 4 lines, and you had to say which one was the longest line. And it was obvious which one the longest line was, but all the 19 people, they would say that it was one that was one of the shortest lines, to see whether that would influence that one person who didn't know what was going on in the group. And it had a massive influence on that single person. And people change their mind because of what the group think. Okay, so if you keep your ideas to yourself and then post them after everybody else has put theirs, then you've got less chance of this bias creeping in. So just be aware of that. It's quite an interesting thing when we read other people's ideas. So this is scenario for the next couple of days. Give you something to think about. Again, there's no right or wrong, there's only hypothesis, and these people don't exist, so you're not going to hurt them, so don't worry. Doesn't matter what you've come up with, it's and what you're going to do, because they don't exist, so don't worry. So we're going to have a look at the history and then sifting through the sieve. So this is the sieve. I've just shared a document with you there, which is our sieve. I'm just going to get this up online for myself as well. Okay, just going to share this with you. Okay, so this is a clinical impression sieve. Just get rid of that. Okay, so what we've got here is the when you hear someone's story, you should think about these things when you're doing a case history. So at the top here, we've got the psychosocial elements of that person's story and their subjective history. And then we've got the biological parts of it as well. So which areas of the body could be contributing to that person's symptoms. We know that in the early stages of injury, things do hurt, but if people have had pain for a long period of time, then it's less likely to do with the tissue damage, and it's more likely to do with the psychosocial factors that are going on in their life. So it's quite interesting. So if you want to download that and then use that as your guide through the next few slides. We don't want to see that. Let's go back to our slides. Bear with me a sec. Okay, so the interesting thing is with the people that you might get in through the clinic. This is adapted from Ben Cormack. Is some people might have more of a biomechanical problem when they come in, and sorting out the biomechanics really helps them, and the psychological part and the social part is not such a big problem. But for some people, the social and the psychological element of their symptoms is really big, and actually the biomechanical part is really small. So everybody is different, and there will be a million of these different circles for everybody, and each person, one area will be more important than another. So we have to look at everything within that person's life to see if there's things that are contributing towards their symptoms, which is what we'll do for the shoulder today. So that was your sieve, which we showed you a second ago. So hopefully you'll be able to download that. If you can't, then don't worry, we'll make it available online for you as well. So this is your scenario, okay? So just go through this, and I don't really want to you to come up with ideas right now. I just want you to just kind of take it in and have a think, rewatch it back again, and then pick out key information that you can then fill in the sieve with. Okay, so what bits do you think are affecting us from a psychological point of view, from a social point of view, and then from a biomechanical point of view? So those are the three key areas that we want to look at. So this lady, Liz, she's 67 years old, has worked most of her life in fashion and marketing. She's 5'7" and 10 stone. She travels by train all over the country in her role and stays in hotels frequently, often entertaining clients. As she follows you to the treatment room, you notice that she looks a little bit anxious and had trouble rising from the chair. And she's very stressed about the work aspect of her life. And she seems to be forgetting appointments and incorrectly completing orders lately. And she's feeling very tired. So just that snippet of information there. And again, you don't have to do it now, but if you do it after this session, just want you to kind of have a look at that and then think, right, what are the key things about Liz that are affecting her life right now, and hopefully you'll get a picture of this woman in your mind about what she's like. So from the job she does. So the social circle is to do with her the things going on in her life, so her family, her job, and all the kind of social aspects of going out, hobbies, that kind of thing. So that's what the psychosocial element is. So it's the psychological side. How does she seem psychologically, and then socially, what's going on in her life as well. So this is her complaint. So obviously we're doing a shoulder patient. So we know a little bit about Liz. We know what she does for a living. We've only got a snippet of information. Obviously there's lots more questions that we would ask. But what we want to know is what that this is what Liz is complaining about when she comes in. So she's complaining of pain in her right suprascapular trapezius area. So around about the kind of top of her neck. Very common kind of shoulder neck presentation. She reports that it sometimes seems to spread up her neck, and then she has associated tingling into all the fingers of her right hand with a cold feeling of the whole hand. Okay, so that's how she's describing it. Just something else here as well, as you go through her history, there's also a right-sided groin ache, which has been present intermittently for the last 2 weeks. Okay, so what we would expect people to do, even if it is a shoulder complaint, we still want to know around about the whole of the body. So we'd ask questions if there's any problems with the knees, ankles, and do a whole scan of the whole body. Liz tells you she has no restriction in the shoulder movement, so the glenohumeral joint. And at this stage, we're not going to comment about that at all. We're just going to kind of leave it there, let you think about it, and then we'll see what you think afterwards. So when you get your sieve, okay, what I'd like you to have a quick go at is have a look at the sieve, have a look at all of the different areas in that sieve, what things jump out for you immediately, and pop them in the chat box if you can. So complete the relevant parts of your sieve. So where does it fit? Does it fit in the musculoskeletal section? Does it fit in the psychological section? Is it to do with the heart? Is it to do with the lungs? All those kind of things, and see. Let's see if you have any ideas. So if we have a look back here, so she's got pain in her right suprascapular trapezius area. So what could that be musculoskeletal wise? See if anybody is going to give us any suggestions for a second. If no one does, then we'll just move on. How about anything in here from her from a psychosocial point of view as well? Is there anything in here to do with her life that you think might be an issue? No takers? Okay, cool. Okay, so we've got neurological, history of any cancer, so things that we want to find out. Thanks, Brendan. What do you mean by neurological? Why have you come up with that? Give you time to type. Yeah, okay, cool. Tension from sleeping in hotels, yeah, stress, good. Yeah, good. Okay, shoulder tension spasm due to stress from work. Yeah, good. So we've got a lot of stress kind of things coming through. Okay, thanks, Brendan. Yeah, so tingling down the arm. So we've got possible neurological symptoms there. I think it's a combination of social due to work travel. Yeah, good. Okay, perfect. Yeah, so hopefully now you're starting to build a picture. Whole hand could look at thoracic outlet. Yeah, very good. Just very quickly, Al, what's thoracic outlet syndrome? Good, Rebecca. Yeah, we'll explore this in a little bit more detail on Wednesday. Okay, so and why it could be one thing over another, but I want you to have a think of it over the next couple of days first. Breathe into that. Okay, yeah, good. Okay, cool. So perfect. So that okay. So what is a thoracic outlet? Good. So if you're not sure what thoracic outlet is, then that is perfect because that is exactly why we're here. So your job between now and Wednesday is to find out what it is. Okay. So if you have a look, Natalie, find out what thoracic outlet syndrome is. We will discuss it on Wednesday. We'll go into it in detail. Because that could potentially be one of our things that we need to look at, and then on Friday we'll look at how to test it. Okay, so perfect. Yeah, so cervical issues, TOS is thoracic outlet syndrome, just in case you're not sure, and then the facet joints are the joints in your neck. So there could be a restriction there that's then causing the problem down the arm. Good. Okay, cool. Some good thoughts. So this is the next bit of Liz. So, okay, thanks, Al. So an umbrella term to a number of problems that could happen to the lateral anterior neck area. Yeah, good. So we've got a lot of anatomy in this area that could be contributing to those symptoms down the arm. So brilliant. That's perfect. So what we'll do is we'll explore those. Yeah, brilliant. Really good, Rebecca. Yeah, good. So we'll explore all those things on Wednesday to see what's going on. Good. Problem has been a feature for 2 months. Okay, so that's been going on for a little while. The onset seemed fairly rapid, and for NAR is no apparent reason. Okay, so this is a little bit more of a history here. We seem to have forgotten, though, about the groin ache. Okay, so we've been really focusing on her neck and we've forgotten about that groin problem that she's had. Okay, so we need to explore that in a little bit more detail. So the groin ache seems to start with a gradual onset associated with a lot of traveling, so sitting on the train, and then long walks from the train station. Okay, so given it again a little bit more history about the onset. The onset's really important when we're trying to figure out what tissue could potentially be a problem. So the daily pattern: groin symptoms are worse following rest, early morning stiffness for an hour, and then shoulder pain is worse in the evening, and the hand tingling gets worse with activity. Okay, so again, these kind of symptoms will give you ideas about what the potential cause of the symptoms are. Okay, so really good so far, and hopefully this will give you a little bit more of an idea. So based on that information, okay, what we want to find out now, is there anything else that you think might be going on based on what you've already seen? Okay, so we know about her job, we know about her stress, moving from room to room, we know about the symptoms in the whole hand, and then we've picked up this groin symptom as well. And the groin ache seems to start with a gradual onset. Okay, so these are a couple of things that we need to think about. Okay, so groin ache could be arthritis. Yeah, so she's in that age range. What does glute dysfunction mean? Okay, so that would be a good question, Rebecca, to see if you can have a look at that one. And firing patterns as well. Okay, so we can have a look at that on Wednesday as well. Something affecting nerve supply as well. Yeah, good. Okay, cool. So it could be a glute referral. Yeah, good. Okay, cool. So we're coming up with some good ones. So what I'll do, I'll make this chat thread available for you as well, so that you can have a look at some of the information that other people have put. But again, try and do yours first if you can before you look at other people's ideas. So next bit then. So walking in general is becoming more difficult. Okay, so Brendan, maybe the arthritis thing might have been along the right lines potentially. And remember, there's no right or wrong answer to this. This is a completely made up person. So that's becoming more difficult and causes more pain for both complaints. Okay, so it's making her shoulder and her groin worse by walking. Okay. Backward bending, so extension with the head, produces sudden sharp lower neck pain. Okay, so bringing the head back into extension brings on sudden sharp pain in her neck. Okay, while she's resting, the groin symptoms feel easier. However, the symptoms return immediately when she moves again. Okay, walking in a forward bent position helps the groin, and there are no relieving factors for the shoulder pain. Okay. Okay, yeah, good. Okay, so we've got osteoporotic risk there, Rebecca. That's good. How she sits while on long train travels, yeah, okay. Could affect her hip complex when held long term and repetitively. Yeah, good. Yeah, so this is the thing. So crossing your legs is not in itself bad, but if you are doing it for long train journeys for the whole 3-4 hours, then that can cause some problems because you're not moving. So it's not necessarily the crossing of the legs, but yeah, the prolonged sitting in that position. Good, Al. Yeah, brachial plexus. Again, linking it back into the thoracic outlet. Could be hip flexors. Yeah, good, Natalie. Yeah, so again, that's another one to add to the list. Good. So hopefully, what you're starting to get now in your sieve is a lot of things in those boxes. Okay, so you need to kind of fill in all those boxes and go, right, okay, what muscles could it be? What joints could it be? What nerves could it be? And you need to list all of the things that it could potentially be, because when we come to Wednesday and we're doing the tests, we need to work out our priorities and which tests we're going to do first. Okay, so really good as we're going so far. Okay, already done that. Right, so the progression. Progression is gradually worsening over time, and that's a bit of a red flag. Yeah, so if something's getting worse, then usually we would expect a muscle issue, if it was a musculoskeletal one, to get better on its own within about 6 weeks. Okay, so usual kind of progression for a musculoskeletal problem, but if it's a muscle one, is usually 6 weeks. So if it's gradually worsening, then that's not good. Yeah, good shout, Kay, with stenosis there. Okay, so recently Liz took her own blood pressure reading with a home device, and her reading was 195/95. She does not know if that was good or bad. Well, I think we can pretty much say that's not good. So yeah, okay, yeah, good. Okay, so we've got whiplash coming through as well. Okay, so she's had an RTA, she's had a road traffic accident as a front passenger in the car. So if you think about the way that you wear a seatbelt when you're a passenger and which way your head will go, okay, if you are involved in an accident. She was hit from behind at approximately 30 miles an hour. So again, we don't know if she was stationary or if she was traveling the same speed, with no idea. But she had no investigation or no treatment after that accident. Okay, so yeah, I would agree with you there, Rebecca. I think that blood pressure is a bit high. So her medication, Liz describes herself as living on aspirin at present. So again, if you're not sure what that does to you, go and have a look, go and research it, find out what taking aspirin long term does to your body. Okay, and then post it in our Facebook group. And again, make sure you've got the references of where you're getting your stuff from as well. Okay, so we want really good academic references for whatever it is that you post in the group. Okay, really good. So a little bit more information and then we're nearly done. So we've got a respiratory and cardiovascular system. So she feels a little breathless when walking. And she's got by good to add to the list. Neurological, so all fingers in the right hand have intermittent tingling and a cold feeling. Okay, mental agility has deteriorated. Liz feels that she is becoming more forgetful and she has daily occipital headaches and she's had those for 2 months. So the occiput is the back of your head, okay, around that area there. She's had daily occipital headaches for 2 months. Gynecological problems or issues. Liz had a total hysterectomy at 40, okay, due to endometriosis, and she has not received HRT. So again, if you don't know, then have a look. What does having a total hysterectomy do to your hormones? And then what are the effects of endometriosis? And what are the effects of not having a hormone replacement treatment after having a hysterectomy? Okay, so yeah, have a look at those things. Gastrointestinal, so around the tummy area, the right side upper quadrant, there's pain, especially in the evening after food. Okay, so that's in the upper right part of her abdomen, and her abdomen feels really bloated. Okay, so that is our history. Sorry, I'm losing the sound. Again, you can have a look back at the recording. Hopefully all the sound will be good on there. What do you mean by scarring, Maria? Okay, so it'd be good to know a little bit more about that. So all other systems explored revealed nothing of significance. So that is a pretty thorough case history. Gallbladder with shoulder pain, gastric, yeah, good, really good. Okay, cool, got some good stuff coming out there. And again, Rebecca, really good one with the gallbladder with shoulder pain. Would like to know why you get that, okay, and why would Liz have those symptoms? What about her lifestyle that makes you think that? Okay, cool. Okay, so your task now, should you choose to accept it, you should have a whole list of things that can be causing her symptoms. What we're going to go through on Wednesday, and if you can have a go at this now as well, what tests can you do to test those things? Okay, outlet syndrome, what test can you do for that? If you think it's neurological, if you think it's appendicitis, then what test can you do to test the likelihood that they have that particular condition? Remember, okay, cool. Thanks, Maria. That's really good. So if you think it's a specific thing, then you need to justify it. So what in the case history made you think of it, and then have a look into the details of that condition as well and why that might be the case. So we'll look at the sieve on Wednesday, and we're going to do another one at 6 o'clock again on Wednesday, and we'll and then after that we'll then on Friday work out a treatment plan and what you would do then. Okay, so another kind of half-hour 40-minute session on both of those days. Like I said before, if you don't want to post them, then send them to me and then I'll post them on your behalf. Okay, there's not a problem at all. If you're worried about putting things down and saying the wrong thing or whatever, no problem, just send it to me and I'll post it for you, no problem at all. If you need help with anything, then I'm always available anyway, but I'm available for one-to-ones online. So if you want to do any kind of education stuff, or if you've got any clinical questions about anything, obviously we're not treating patients at the moment, so usually I would help out with patients. But as an opportunity to book sessions with me, if you want to, I'm pretty free at the moment, so as I'm sure you guys are. But we're going to be putting out at least 3 sessions a week through this platform, and we'll follow a similar kind of format each time that we do it, so you'll get used to the kind of things that we'll do, and we'll run through the whole body and give you loads of different ideas. Yeah, loads of different scenarios and things to think about. So pop any questions in our Facebook group. Thank you for contributing on the chat. Really good. And I will see you again on Wednesday. Thanks, everyone.